Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hands.org/dental-training. For future inquiries, contact Facilitator.
Okay, welcome everybody. I got this nice invitation to speak to you all about bone grafting, my approach to it. I'm an oral and maxillofacial surgeon at the University of Michigan, and thank you again, Uvo, for the invitation. It's nice to see so many people from all around the world, and hope everybody's staying safe and healthy in the middle of this pandemic. So what we want to achieve ultimately is a good occlusion, functional occlusion, nice looking teeth, good healthy periodontal structures, and we also want to consider the facial soft tissue. So a lot of times, really in dentistry, we're reverse engineering what it is that we look at the final product. What do we want for lip support? What do we want for smile aesthetics, etc., and function? And we move back from there and say, well, where do we need the teeth to make this happen? Or do we need, a prosthesis that incorporates a flange? And, based on that, what kind of soft tissue, periodontal structures do we need? What kind of biotype do we need? What kind of bone do we need? And where do we need the dental implants to replace missing teeth? I try to remind patients that regenerating bone and placing dental implants to replace missing tissue like teeth, gums, bone, these are regenerative procedures, and not every single person's body can regenerate missing tissue, and so it requires a healthy host as well. There are many things to consider before we proceed with bone grafting. A lot of that is in the realm of treatment planning and trying to figure out which teeth we're trying to replace. Are the adjacent teeth healthy? Is there adequate spacing mesiodistally for those teeth? So for instance, if we're replacing a molar tooth, we ideally want about 10 millimeters of space, maybe 8 or 9 might be enough. If we're replacing a premolar, we ideally want 7, sometimes 8 millimeters of space. And we need to make sure that space is there. And we also want to consider how much room we need vertically for emergence to have a nice aesthetic emergence, which will affect the appearance of the papilla, will affect the likelihood of being able to maintain good oral hygiene, or whether or not food might get trapped under the restorations. When we think about where we want our implants to be placed, we typically, from looking from the kind of buccal aspect, we want the implants to be, for instance, in a premolar area, to be fairly parallel to the adjacent premolar and molar in terms of the long axis of those teeth. And when we look down from the frontal aspect, from anterior to posterior, we want an implant in the premolar area, for instance, to typically the center of that implant should line up with the central groove of the teeth posterior to it. And again, it should be nicely lined up. And you can see here's an example of a patient where there's very minimal mesiodistal spacing. There may not be enough room for a normal looking tooth, but we may not have enough room for an implant. And many of the if we look at a lot of the dimensions, there are some guidances about minimum amount of space. So we should have at least a minimum of 1.5 millimeters between an implant and the adjacent root. But that doesn't mean that we want the implant to be 1.5 millimeters away. The implant should be centered over where the center of the tooth will be. So, think about the central pit or the central area between the mesial and distal pits of a premolar, and that's where the center of that implant should be. So if it's a 7 millimeter premolar, then we want to be 3.5 millimeters distal to this canine tooth. Just a minute. Okay, sorry about that. Similarly, if we have a patient that has a certain curve of spee to their mandibular or maxillary arch, we want to think about placing our implant in such a way that we're going to be bisecting the curve of spee. In those situations, we can't be perfectly parallel to the long axis of adjacent teeth, especially when we have a more distal tooth that may be mesially inclined. And we got to think about the depth. How far, how much vertical clearance do we need for this tooth? Is this tooth going to be, directly screw retained to the platform of the implant, or will this tooth, will there be a restorative abutment between the crown and the implant? And all those things will affect how much vertical clearance we need. And we have to take into account the position and location of the inferior alveolar nerve in the mandible, in the maxilla, the location of the sinuses. Here's an example of a patient who is edentulous, and for an edentulous restoration, you got to look at soft tissue lip and nasal support. And for patients that need more lip or nasal support, those patients can benefit from a hybrid prosthesis or removable prosthesis that has a flange, ideally removable probably, to give them some additional support in that area and be able to remove it and for hygiene and cleansability. This case here is a patient that had oligodontia and a very small mandible. It was very retrognathic. As a child, this patient had a brain tumor and required chemotherapy, and this chemotherapy caused agenesis of multiple teeth. And so I first advanced his mandible with a bilateral sagittal split osteotomy. It was a very large advancement, so I placed bone grafts and 2 long plates. And then I came back and we placed 4 implants in what's called the all-on-4 style with 2 distally angled implants. And one of the biggest, challenges in these cases, in a patient who has a very short anterior face height, is vertical clearance. And so sometimes we may look at a ridge and say, oh, that ridge looks too thin, we need a bone graft. Well, that's not always the case. It all depends on how much vertical clearance you need. And if you need the implants to be further apical for the vertical clearance, then you got to look to see and plan this on, in a 3D, based on 3D imaging, to see where the implants need to go. Do we have enough bone there? That's the key, really. And sometimes we may not be able to remove enough bone to create vertical clearance. In some of those cases, we're going to need to increase the vertical dimension of occlusion, because we don't want to create a situation where we turn somebody's mandible into a really vertically atrophic mandible either. This is a nice paper from the Journal of American Dental Association from 2019, discussing the hierarchy of restorative space that's required for different types of dental implant prosthesis. And they did a literature review, and as you can imagine, there's many different opinions and from different authors in the literature, but there's several different factors that you can look at, both intraoral and extraoral, to determine whether you should consider fixed versus a removable restoration. So an example of that is ridge shape. If you have a vertical or convex ridge shape, which probably supports the lip really well too, then you may tend to lean towards a fixed prosthesis. If you have less interarch space and you're going to be doing, teeth directly to implants, that also favors fixed prosthesis. But again, that may not be the case if you're doing a hybrid prosthesis on a bar where you need more space. Interarch relationships, if they're kind of class 1 or slightly deep overbite and mucosa keratinized, that favors fixed prosthesis. Now, if you have more of a buccal concavity and a buccally inclined alveolar ridge, if you have increased interarch distance greater than 15 millimeters, if you have more of a class 3 type relationship where you need to cantilever more, and thin mobile mucosa, those are some intraoral factors that increase the likelihood that removable prosthesis will be more favorable. From an extraoral standpoint, we got to look at the smile line. Where is the lip line when a person smiles? Tooth display, facial support. If you have very minimal facial lip support needs, if there's minimal or little tooth display and a low lip line, then fixed prosthesis is going to work very well. But when that lip line is high, there's excessive tooth or gingival exposure, and you need more facial soft tissue support, you should be thinking removable prosthesis more likely to achieve that. So they had a nice table showing all the different different kind of minimum vertical space requirements. And again, understand this is the bare minimum. It's not what you ideally want. You want more than this, even if you have this minimum, because it's going to be, the closer you are to these minimal numbers, the more difficult it's going to be for the restoration. So, if you're doing a screw retained crown directly onto the implant platform, 4 to 5 millimeters is the minimum, and that 5 millimeters is from the platform of the implant to the opposite arch, to the occlusal plane. If you're using a screw retained option with an abutment level prosthesis, then you need more space, a minimum of 7.5 of interarch space, and so on and so forth. Bar overdenture, there's been anywhere from 11 to 13, 14 millimeters of space. Screw retained hybrid requires more than 15 millimeters of space. So you can see many, even for unsplinted overdenture, many different articles quoting different things, and it depends on the individual patient situation and your experience as a restorative and provider and implant specialist. So when it comes to reconstructive options, there's various types of bone grafting techniques. In fact, many different techniques are available to rebuild similar defects. And so ultimately it comes down to mastering a technique that you know how to do well and figuring out which technique works best in which situation. And that comes with experience. There's certainly the option of block grafts, which can be autogenous grafts, or it can be cadaveric grafts are now available as well. I'm sure there's probably some other options for block grafts as well. These can be onlay, like veneer graft, or it can be an inlay. It could be interposed between an osteotomy, for instance, in a situation where we're trying to gain vertical bone height. We can also use guided tissue regeneration. It's probably the one I use the most commonly with particulate or cancellous bone. This can be autogenous, cadaveric, or alloplastic. And we can support this with tenting screws or a titanium mesh if we need to. And then there's also even the option of distraction osteogenesis to regenerate bone, especially for vertical defects. We also have to consider the soft tissue biotype. A healthy biotype is essential for long-term implant health and for aesthetics. And we have to consider whether there's a whole variety of different soft tissue procedures that we can perform. Sometimes this is done at stage 2 implant surgery to reposition palatal tissue to the labial aspect. We can deepithelialize some of that tissue, and we can tuck in connective tissue under our labial or buccal flap. We can take a connective tissue graft from the palate or the tuberosity. There's also a variety of off-the-shelf options that are available. Free gingival graft is important, especially when patients have a lack or inadequate attached gingiva to support the long-term health and hygiene around the implants. And yeah, there's some commercially available products. I don't have any commercial ties or any anything to disclose with regards to any type of conflicts of interest. I do like using membranes. Cross-linked collagen membranes are available, and they basically help cover your particulate graft. These are typically cell-occlusive membranes, so they prevent the ingrowth of epithelial cells and other soft tissues, and they protect the bony regenerate. They do allow plasma and oxygen and nutrients to diffuse into the regenerate to allow that bone regeneration, which is typically slower than growth of and reproduction of epithelial cells. And so it allows a slower proliferating osteoblastic cells to populate the regenerate space instead of fibroblasts or soft tissue ingrowth. And in more challenging defects where patients have had prior bone graft failure, or there is poor vascularity, maybe there's scar tissue of the overlying soft tissue envelope, we may consider using some growth factors like recombinant human BMP2, which is bone morphogenetic protein, which is osteoinductive. Some like to use platelet-rich fibrin or platelet-rich plasma to help congeal the cancellous particulate bone together so it holds together nicely. Those membranes can also be used as a barrier in the sinus or at the apical aspect of a graft if we can't get coverage with a collagen membrane. And some articles have been described using platelet-derived growth factor as well. So there's various types of bone graft material. Allograft is a graft taken from the same species. So this is typically human cadaver bone. It can come as a cortical cancellous graft. It could be particulate or as a block. And there is kind of the demineralized and mineralized versions of this. I prefer mineralized, freeze-dried bone allograft personally, since it tends to have greater dimensional stability for holding the space. And sometimes I use a layer technique of combining allograft and xenograft. Allograft is replaced at a faster rate than xenograft and is incorporated into the surrounding bone at a faster rate. Xenograft is going to be typically bovine bone, but xenograft has excellent space maintenance capabilities, and it doesn't get resorbed as quickly and can hold the volume and thickness of the ridge that you've built. I don't use a lot of alloplast, but it has been described as an option as well. And technically it doesn't have the risk of disease transmission like allograft or xenograft. However, I would say it's extremely rare to have any problems with these bone grafts in terms of the quality of the graft, the selection of the host species, and the way they're processed seems to be very, very predictable. So when we think about the characteristic of a bone graft, we want to think about three different things. Typically, osteogenesis. Only an autogenous bone graft, a bone graft from your own body, is osteogenic because it has not only the scaffold and the bone matrix, but it also has osteocytes, osteoblasts, and osteoclasts. It has cells that help with bone formation, and so only autogenous bone is osteogenic, and will actually start making osteoid after it's been grafted. Autogenous bone is also osteoinductive and osteoconductive, but other bones, other types of bone grafts may, and most of them are just osteoconductive. They provide a scaffold onto which the body will replace that bone with, or those particles with new bone. Some of the bone grafts, like demineralized freeze-dried bone allografts and demineralized bone matrix, are also known to have some mild osteoinductive capabilities. They can induce surrounding multipotent progenitor cells to turn it into osteoblast and bone-forming cells. And this is also what bone morphogenetic protein does. Bone morphogenetic protein exists in our own bone, especially in the cortical part, and has been isolated, and through a DNA recombinant technology can be used to kind of supplement a bone graft. So when we think about bone grafting for dental implants, there's really three kind of stages. There's the sinus socket graft, which is a ridge preservation graft. When we remove a tooth, we have to consider if we should replace that bone or put bone in the socket. Ridge augmentation graft, where we are building what is now a resorbed ridge, horizontally or vertically or both. And sinus augmentation in the posterior maxilla. So here's a patient who was referred to me for removal and placement of an implant at a premolar site in the left mandible. This was just in front of the first molar tooth, so tooth number 20 here in the American nomenclature, but basically the second premolar. And looking at the planning here with 3D imaging, we could see that there's root resorption, and we can also see that there's been some loss of the buccal plate. So there's a lack of buccal plate. And in those situations, I don't like to place an implant if there's no buccal plate in place, if you're considering an immediate implant placement. So based on that, I decided to extract the tooth and perform a ridge preservation graft. In this situation, when the buccal plate is missing, I use a little thin Woodson elevator and dissect subperiosteally to make a tunnel between the remaining buccal plate and the mucoperiosteal flap, preserving the periosteum. And we slide a cross-linked collagen membrane down between periosteum and the bone. And then we pack a bone graft. Usually I typically use particulate allograft. So this is human cadaver bone that's rehydrated and packed in place. And then I cover this either with a membrane or with platelet-rich fibrin. So the idea is, we know that when teeth are removed, we're going to start developing some bone loss. And the amount of bone resorption varies from patient to patient, but can be substantial enough after an extraction that we may not be able to place a dental implant after healing. And so we have to look at the thickness of the buccal plate. If the buccal and palatal plates are intact and are present, if the buccal plate or the labial plate is at least a millimeter thick, then we may not need any ridge preservation graft, socket graft. However, if the buccal plate is quite thin, we can be quite sure that we will have enough resorption that we will have a buccal bone defect. And so placement of a socket or a ridge preservation graft at that time will make sense. A lot of times clinically, we want the stage 3 kind of bone. And if I'm not placing a ridge preservation graft, and I think there's enough bone, I may even go in and do an early implant placement after allowing some initial healing if I'm not doing an immediate implant. Many of the cases that I see are in the stage 4 or 5 classification of alveolar ridge resorption by Cawood and Howell, and occasionally stage 6. So, you know, when it comes to reverse engineering, we can look at a big defect and say, where do we need the teeth? And I think it's important to decide with the restorative provider, where are the teeth going to be for the occlusion? And then we can wax up the ridge and say, okay, this is the ridge that we need. It's a big, big ridge, but we have to ask ourselves, you know, if we're planning for a big graft, you know, we have to be practical. Are we going to be able to stretch the soft tissue, especially in a patient? This patient was in a motor vehicle accident. She lost many teeth and bone and soft tissue. She has a lot of scar tissue. Are we going to be able to stretch that tissue to cover over this bone graft? In this case, I had pre-bent a titanium mesh, and then I sterilized it and planned for a large graft, but I didn't have enough soft tissue mobility to close over it. So I ended up having to put a smaller graft sometimes in those types of cases. So you have to think about practicality. Sometimes the bone and the implants will not be in the ideal position, or it might be further palatal in a situation like that. And then we have to think about how we're practically going to get the teeth there. So maybe some kind of a fixed hybrid prosthesis or something else, but it may not be, a crown to tooth kind of 1-to-1 type ratio. Here's an example of a lady who had squamous cell carcinoma, and she had a marginal mandibulectomy. And you can see that she has a significant vertical bone height loss in the left mandible, and the nerve is quite high. We traced out the nerve after obtaining CBCT scan, and we can also see that she's got some vertical bone loss around her mandibular incisor teeth. She wanted to keep some of her dentition on the right side, so we discussed a plan to place 3 implants that's going to support a bar and remove the remainder of the incisor teeth. And in this case, we see that when we place these implants further apically, we do have at least 1.5 millimeters of bone around the implant on all sides. So we can make this work and kind of come up with a compromise. And this requires great communication between surgical providers and restorative provider. Here's a patient who was seeing me with extensive resorption of her maxillary incisor teeth after orthodontics. Root resorption is actually quite common with orthodontics and is genetically based. And apparently about 25% of patients who undergo orthodontics develop some root resorption, but I think it's a smaller percentage in which the root resorption is so severe that the teeth are mobile and need to be removed. So we can see in this case, there is a concavity along the labial aspect of the ridge, and if I simulate implant placement, I could see I don't have enough labial bone in order to successfully support this implant. My preference is to make sure I have at least 1.5 millimeters of bone all around the implant, and obviously we have to account for kind of the emergence of the crowns, etc. So I'm going to choose to bone graft a case like this to make sure that we have good bone support everywhere around the implant before placing it. This is a nice article by Dr. Priest summarizing the dimensions to keep in mind. So when we think about where and how to place anterior implants in the anterior maxilla in the aesthetic zone, we want the center of the implant to be 3 millimeters away from the planned labial most aspect of the crown of the tooth. We also want ideally 2 millimeters of bone anterior to the implant. So 1.5 millimeters is the minimum, but we want ideally 2 millimeters for great aesthetics and support, and especially in a patient with a high smile line or a thin biotype, to make sure that the implant doesn't show through. We want a minimum of 3 millimeters between implants for blood supply, and to make sure that we are able to preserve and achieve a good papilla, but 3 millimeters is the bare minimum. In many cases, we want a lot more than 3 millimeters. It really depends on where the center of those teeth are going to be, and that's really where the implant should be. And then we want at least 3 millimeters vertically between the implant platform and the zenith of the marginal gingiva. Sometimes even 4 millimeters if we're trying to correct for implant angulation discrepancies. So keeping all that in mind, when you're thinking about placing your implant, even if the bone may be thin in some areas, more crestally, look to see maybe you have enough bone where the implant needs to be, and maybe you could graft and place the implant at the same time. If not, if I'm on the fence, or if there isn't enough, I like to be more conservative and try to do a separate bone graft first to make sure that the implants are going to be in great bone. So here's an example of a typical ridge defect that I see, extensive kind of hourglass buccal bone loss. And so we're going to build this up, and we're going to put bone there, typically particulate hydrated allograft bone, cover it with a membrane, mobilize the soft tissue flap and achieve good closure. So the question is, which technique should you use? This is one study by Dr. Agalou and Dr. Peter Moy, where they reviewed really a large number of papers. It was a systematic review of all the different types of bone graft techniques, like guided bone regeneration, onlay veneer grafting, combination grafting, interpositional inlay grafting, ridge splitting, distraction osteogenesis, and they found that all the techniques had a high success rate. So the point is, learn the technique, learn a few techniques well, and figure out which situations you should use them best. This is an article that kind of describes the guided bone regeneration technique for using a combination of autogenous bone with or without bovine bone, with a membrane. And kind of this is the typical technique I use. I expose the site. I perform recipient site preparation with corticotomies. In this case, they also had a sinus lift. I hydrate my bone graft while I'm doing all this. I mobilize the flap. I score the periosteum to release and make sure the periosteum is free for tension-free closure. I place my bone graft. Typically, before I place the bone graft, I will suture a cross-linked collagen membrane with horizontal mattress sutures using Vicryl, typically polyglycolic acid. I'll suture it to the palatal flap. On the mesial and distal side, I'll make sure that my membrane is ready to cover over the graft, and I'll trim it so it's at least about 1 millimeter away from adjacent teeth. I'll put my bone graft into place and then cover it with the membrane and use some membrane tacks usually with a little mallet. We'll place those membrane tacks into place apically, mesially, and distally, and now the bone graft is completely covered, and then we close. When we come back, usually I come back 5 to 6 months after surgery and place the implant. I always obtain 3D imaging after the bone grafting to plan the implant position, and ideally, if you can do the 3D imaging with the radiographic guide that shows where the teeth are going to be, that's the best way to do it. So here's an example of some areas where I take bone grafts for larger defects where there's poor blood supply. Or I worry that there may be poor cellularity in the area, especially multiply operated areas. I may take an iliac crest bone graft. Sometimes I take a tibia graft. I frequently also use these to reconstruct alveolar cleft defects in patients with cleft lip and palate. Here's an example of bone taken from the tibia. You can see the cancellus, and you can get a cortical cancellus block there too. Here's a patient that had, it was a police officer that was shot in the neck, and he lost a bunch of bone in the mandible, as well as teeth and bone and teeth in the maxilla. And so he was referred to me by a colleague of mine, and he had a very, very challenging defect. So what I decided to do is I took iliac crest bone. It's very convenient. It's easy dissection. And, patients usually stay in the hospital for one night and go home. And what I did is I took basically a slab of cortical bone that I adapted, and I secured it with very small 1.0 millimeter screws, mesially and distally. And then I dissected on the lingual aspect and released the mylohyoid muscle a little bit, and I placed the lingual slab of bone and secured the buccal and lingual bones with a 1.5 millimeter screws that are essentially engaging bicortically, kind of creating a sandwich. And then we use the rest of the marrow bone from the iliac crest. This is all autogenous bone to pack the defect. So this way we're able to gain a lot of vertical bone height in a very predictable way. Of course, this requires excellent mobilization of the soft tissue to free it up and dissect. I usually dissect between the periosteum and the submucosa using fine dissecting scissors, and I create a pocket and cut it. I make sure to stay away from the mental nerve. And again, how high do you want this to be? Well, think about where you want your implants to be, and you don't want to overdo it, because if you're too high up, and you're too close to the teeth, you may have problems with tissue dehiscence or infection, or you may not be able to close over this graft with the soft tissue mobilization. So we have to mobilize his soft tissue on the lingual and on the buccal aspect. And then I decided to cover this whole thing over with a collagen membrane and membrane tacks, just because I didn't want any soft tissue ingrowth into the marrow area. But typically, if any kind of cortical grafts, the cortex itself provides an adequate barrier, and you don't have to worry about soft tissue ingrowth around the cortex. So here we are, 5-6 months later. I also did, prior to the bone graft, I did a free gingival graft for this patient, and I removed one of the molar teeth, which was compromised with a lot of bone loss, building up the soft tissue sometimes before the graft also helps with predictability of keeping the soft tissue closed. You can see over time he started forming a little breakdown over one of the screws. We went back in and you can see the graft nice and thick. We took the screws out and placed 3 implants and canine, first premolar and first molar area. And another area where I frequently will take dental implants, where I may take bone grafts, actually infrequently I should say, is a posterior iliac crest bone graft. This requires a supine position. It's usually done in the operating room, and this is where we can get a lot of bone. This was for a patient who needed a large mandibular advancement that had cherubism and had a lot of abnormal bone, requiring interpositional bone grafting. For atrophic maxilla, for full arch maxillary reconstructions, I frequently will use cadaveric blocks. Cadaveric blocks have no donor site morbidity. They're readily available. They are expensive, but you don't have the added time to harvest the bone, and you don't have to worry about the morbidity of harvesting bone. So here we took a patient. This is a patient who gets 4 block grafts to rebuild her maxilla. You can see I use a lag screw technique here, which means that I use a larger drill bit through the graft and a smaller drill bit through the recipient site bone. Again, just like in the guided tissue regeneration technique, I always perform a recipient site preparation, and I create ledges and decortication of the recipient site. I make sure to place these bone grafts a little bit more apical to the crest, to decrease the chance of dehiscence. And I shape these grafts until they adapt very, very intimately to the underlying bone. We don't want any gaps or spaces between the bone graft and the recipient site. This is very important, I think, and I typically use some pretty long screws. And again, in these cases, full arch restoration, you got to think about the smile line, the lip line. You got to think about vertical clearance for the final prosthesis, and where should the implants be vertically for these patients. But again, I do like this, and this is an example of a case where I also built up the palatal bone. This was probably a little bit excessive, but the patient had a very, very thin ridge with inadequate palatal shelf and buccal plate, and he needed also a sinus lift with augmentation of the bone coming out of the sinus in a guided tissue regeneration fashion. Sometimes I'll combine block grafts and adjacent guided tissue regeneration, and frequently when I place a block graft, I will support it with some particulate bone to create a broader base, which will decrease the amount of stress that the soft tissue is exerting on the graft and help prevent excessive resorption of the graft during the healing process. So you can see here's an example of a patient with 4 block grafts. And you can see how thick and generous these ridges are. Frequently after we plan the implant placement, frequently the implant, we try to get the implant into some of the native bone in the recipient site, and obviously part of the implant is covered by the grafted bone, because remember, grafted bone can resorb gradually over time, even after placement of the implant. So we definitely want the implant to be partly in some of the kind of native bone at the recipient site. Here's an example of a patient who had a traumatic defect and lost multiple maxillary teeth. You could see that he has a kind of a class 2 overclosed occlusion, some crowding, and a lack of interarch space. And you know, this is a case that I treated, you know, where I was focusing on the horizontal maxillary projection, and we worked this up with an orthodontist and the restorative dentist, and it was clear that the patient was not going to have adequate interarch space, and so we would need to commit to orthodontic treatment to open up the vertical dimension of occlusion, in addition to building up the ridge. And here we see kind of a guide, a surgical guide, telling us where we want the teeth, and I waxed up the ridge to determine what the ridge kind of width was ideally. You can see pre-op to post-op, what we want for this ridge, and I used the titanium mesh that I bent to this defect, keeping it away from the adjacent teeth, and we have to contour this around the piriform rim as well. And because this was a traumatic defect with a lot of scar tissue, I decided to use a combination of bone morphogenetic protein, which is osteoinductive, along with some allograft human cadaver bone, and mix this all together into like a slurry. And so this bone morphogenetic protein is reconstituted, and then it's dropped or dripped onto these collagen sponges, and then we cut the collagen sponges and mix it with the hydrated allograft bone, and we contain all this with the titanium mesh here. You can see to avoid, you know, excessive resorption in this case. I don't think this is necessary in every case, but I chose to use it in this particular case because the soft tissue looked quite contracted, and I was worried about excessive bone graft resorption. The one problem with these titanium meshes is that they need to be very, very well contoured and smooth. Any sharp bends in these, if they're not completely smooth, the soft tissue will break down over them. And the incidence of soft tissue breakdown is about 25 to 30% in one study that I saw. Again, you can cover this with a cross-linked collagen membrane. In this case, I don't think I did. But I covered it with the bone morphogenetic protein membrane, and that typically is enough. And you can see after 6 months, you have a lot of bone. When I use bone morphogenetic protein, I typically will wait at least 6 months because of the endochondral ossification that occurs as this bone regenerates. And, you know, at 9 months, the bone is very solid. At 6 months, it's still going to be a little bit soft. So plan for that. And as you can see, yeah, the bone looks great. It looks great in 3D. But look now, the patient has no interarch space because there's so much bone there. So again, treatment planning, just as important, you know, before you bone graft. And this patient ultimately had 3 implants placed and or you can see the orthodontic appliances. The orthodontics were used to open up his vertical dimension of occlusion as we were waiting for the bone graft to heal. And you can see the restorations in place. And actually, as I was preparing this presentation, I was looking at some of these x-rays that were sent to me by the restorative prosthodontist. And I want to criticize myself here a little bit because I didn't really give enough vertical clearance for these teeth. Look at this restoration. It's a screw retained restoration that's directly at the implant platform level. So there's no room for a restorative abutment. And you can see the emergence of this central incisor crown from the implant is quite poor. It's boxy. There's not enough room for emergence. So if I can criticize myself, I should have placed these implants more apically in a vertical sense to allow more room for emergence here. But thankfully, he's maintaining this with good crestal bone height, and the prosthodontist was able to make it work. So when I think about the technique, think about your choice of bone graft that you want to use and material. Think about the incision design. How do you want to expose it? The incision design will depend on the biotype, but also depend on the extent of the defect. Mobilization of the flap. You want to make sure the flap is nice and free so you can get tension-free closure. You want to prepare the recipient site. Typically, this is corticotomies if it's a guided tissue regeneration, if I'm putting a block graft, the recipient site preparation will also include making ledges apically, mesially, and distally. Then we have to decide if we're going to hydrate bone that's off-the-shelf bone, or we're going to harvest bone from the chin or the mandible or some other distant site. There's obviously multiple ways to harvest bone. You can harvest bone with a trephine. You can use a bone file or a bone scraper rather. And then you want to immobilize your bone graft and membrane and get your tension-free closure. So let's take this case as an example. Pretend the premolar tooth is not missing. This was a patient of mine who had a congenitally missing lateral incisor and premolar, and there was a buccal bone defect there, and you could see the defect. So, there's been many different incision designs described. One of the incision designs is this one, where it's papilla sparing, and you have to be very careful when you incise and elevate not to elevate the papilla, because when you make these incisions, the papilla here really require to survive, it must stay attached to bone. Otherwise, it starts becoming blue and kind of congested looking. So this would be really ideal. You want to give it at least a millimeter and a half. And this type of incision design is fine if you're just trying to build up a little bit of bone in the labial concavity here for the implant. But it does limit you quite a lot. If you're trying to extend the bone, or if you're trying to secure a membrane with a membrane tack further out around the bone graft, it really limits you because you have to do everything within that space. And you cannot augment the bone beyond the labial projection of the adjacent bone that's at the incision site. And usually you're not going to extend your bone graft all the way to the incision because you want to make sure that your incision will be closed and will not break down over the bone. So this is excellent for just a localized apical defect. You can extend this a little bit. I think I saw this type of design from Dr. Anthony Sklar's book, where he extends this incision further out. Again, very important to just not elevate the tissue that's supposed to be preserved here for the papilla aesthetics. Now we remember, based on the position of the lateral incisor here, we remember that usually the zenith of the marginal gingiva is going to be about 1 millimeter more incisal than the canine and the central incisor tooth. And we want our implant to be 3 to 4 millimeters apical to the zenith of that marginal gingiva. So we want to think about what does the bone look like in that area. So 3 to 4 millimeters. Remember that kind of 3-3-3 rule by Dr. Priest, right? And I like these types of surgical guides that are kind of like a vacuum shell that just shows me the incisal aspect of the crown and where we want the center of the implant to be. Because this is a good guide, but it doesn't interfere too much with the implant placement. So another incision design, if we want to build bone a little bit beyond this area of the papilla, we can make a vertical release that includes the papilla. But again, we may be concerned about loss of papilla tissue. So suturing that back with vertical mattress sutures and very precisely is important. And we also, what I don't like about this incision design is typically this incision falls right over the canine and the central incisor eminence and is more likely or at risk of breaking down, and then you can have exposed bone and fenestration here. So for that reason, I don't like this incision design. We can take the incision further away and we can place vertical incisions further back. Some people, if you have a kind of a high smile line, some people are concerned about some gingival scarring showing when a person smiles, although I haven't seen much scar tissue form from these. But one of the reasons I don't like this option is because when you close over your bone graft, sometimes you lose a little bit of length and you may not be able to pull this gingiva all the way back to the papilla. And so that again may leave you with a defect right over the labial aspect of the canine or the central incisor tooth. So here's another option. You can take your incision further back and include the papilla here. But again, you have to make sure to suture these papillas very carefully back into place, and you have to make sure that you get enough volume of papilla that you don't develop a black triangle. Currently, my preferred way to make the incision is, from the crest and coming around. I like kind of a broad-based exposure so I can get my membrane completely around the bone graft and tack it down and get tension-free closure. I want the incision to be further away from the graft where I don't have to worry about a dehiscence. And in this approach, it's papilla sparing, and we can release this. And again, it does require careful closure with a small tapered needle. I typically use 4-0 Vicryl sutures for this, and get a nice closure. And I saw this in several articles in a meeting, and this is currently my preferred way of raising the flap. So here's an example of of a paper here from the University of Michigan and other collaborators describing a vertical bone grafting technique. This can also be used for horizontal grafting technique, where basically what they're doing is, you can see it's the same approach for the flap design, but freeing up the periosteum from the submucosa and suturing to the periosteum labially and palatally to contain the membrane in place. I typically suture the membrane to the lingual flap in the mandible on the distal and mesial aspect. I take bites so that it's a horizontal mattress suture, and then I secure the membrane with membrane tacks on the labial. But sometimes on the labial aspect, you may be very close to the mental nerve here. It is more challenging sometimes to be able to get the right angle to get membrane tacks to hold against the bone here. So using this approach is also a good alternative. And you can see in the cross-sectional view those sutures holding the membrane in place. Here's the last case that I'll show. And I'll look at some of the questions in the chat. This is a young lady who had some trauma. She fell, she lost her incisors, and also had poor prognosis with very short roots associated with her maxillary lateral incisors. You can see that she also had a little bit of, I don't know if this was a Bolton discrepancy, but she had almost a little bit of a class 3 tendency anteriorly with regards to her dentition. Her molar is class 3 on the right side, a little class 3 on the left side as well. And you can see that her maxillary lateral incisors were a little bit labially proclined. So this can present a challenge too, but she was already post-orthodontics. You can see those lower incisors are a little large, so there may be a little Bolton discrepancy there. You can optimize a case like this if the patient is in the middle of orthodontics. You can have the orthodontist perform some interproximal reduction, so IPR, and retract those lower incisor teeth, especially if they're a little bit labially proclined. What we did is we, basically went ahead and exposed. This was part of a study, so she was part of the treatment group that had to obtain autogenous bone graft. We extracted the lateral incisors and basically performed a socket preservation graft in those areas. And this is my approach to a ramus graft, an incision along the ramus and in the third molar area. And typically I'll look at the Panorex or a 3D image to see where the inferior alveolar nerve is. You want the mandibular nerve to be at least a centimeter apical to the crest. And the higher up you are on the ramus, the lower the chance of getting the nerve. Again, a lot of these osteotomies done with a Fisher burr just through the outer cortex, and then using some chisels and mallets to free that bone graft. And then you can see using a lag screw technique and recipient site prep, putting the graft in place, and getting a CBCT scan, planning for the implant position. In this case, the restorative provider wanted 3 implants, and that's what we did for her. You could see the ridge width that we built and 3 implants. I would say that probably these 2 implants are a little too close for my preference, because but this was restoratively guided based on the position of the teeth. But you want to maintain adequate space there for blood supply, so you can maintain your papilla and maintain your inner implant bone there. 2 millimeters is the very, very bare minimum, but 3 millimeters is the ideal minimum. After bone grafts, especially like ridge augmentation grafts, I typically have patients on a pureed and liquid non-chew diet for 4 weeks. That's my personal preference because usually at 4 weeks, the soft tissue is completely healed and the periosteum is reattached to the bone graft is stable. Oral care usually involves saltwater rinses twice a day, chlorhexidine rinses, and using a Q-tip soaked in chlorhexidine to clean over the sutures and the incision sites gently. Antibiotics, I usually like to give antibiotics before surgery, and there is a role to consider even like oral care. You need great hygiene and using even antiseptic rinses before surgery to minimize the microbial load. We give patients some analgesics for pain relief. If we're doing a sinus lift, the patient needs to be on sinus precautions. And I'll typically see patients 2 weeks after surgery. All the sutures are resorbable, but you can certainly use non-resorbable sutures and remove them. Also, all the collagen membranes that I typically use are resorbable, so they're typically reabsorbed by the body by the time I'm going back in to place an implant. As far as maintenance of aesthetics, using a flipper or an Essex retainer is great. I just don't want any pressure on the gums or on the soft tissues that are trying to heal over the bone. Even after the initial month after surgery, I really don't want any pressure on the bone graft. So we want to avoid using a flipper where there is a ridge lap or something that's going to put pressure, because that pressure is going to lead to earlier bone resorption. And then when you come back, you may not have enough bone to place an implant. So just something to consider there. And that is my lecture there. Let's see. I'll take any questions now. I see there's a question here in the chat. Can we recognize old bone graft? And if there is resorption in it, does that affect if we need to do a new bone graft? So when we go back in an area that's been previously grafted with guided tissue regeneration, let's say we've used cadaveric bone, human cadaver bone, or bovine bone, that bone sometimes may be visible, and it may be, ideally, by the time we go in, usually 5 to 6 months is my preference, that bone is well integrated. You may see that bone, but even if you can see it, it doesn't mean you need a new bone graft, because typically it'll be mixed in with the patient's own autogenous bone that's grown into that area. When there's severe resorption and the mobile mucosa is near the grafting, is the grafting correcting this condition? So that's a good question. I mean, I would say bone is the most important thing when it comes to being able to place an implant and for the aesthetics. But in many cases, I will do the bone graft first, and then I will if I then see that there's a need for soft tissue grafting, like free gingival grafting, or to build up the soft tissue with connective tissue grafting, I'll typically do this after the bone graft, most commonly at the time that I expose the implant during the stage 2 surgery, or separately sometimes. So that's my typical approach there. And I always tell patients there's always a chance that we may need to do some soft tissue grafting. So there's another question here: which is better, natural bone graft or synthetic one? And so that's a certainly, depends case to case. If you're performing a ridge preservation graft where you have a low likelihood of problems, and you have a lot of surrounding progenitor bone cells, or you have a lot of surrounding good surrounding blood supply, then a synthetic bone graft like an alloplast could work very well. But if you have a challenging, severe horizontal or vertical bone loss case, you may need to incorporate some autogenous bone there, so you can bring some cells and growth factors to the area. Some patients, for personal reasons, will prefer to avoid bovine bone or prefer to avoid any cadaveric bone and want to have their own autogenous bone, right? And so that's fine too, but you just, they have to understand that it requires a donor site, and there will be pain and swelling and the risks of donor site morbidity, like nerve damage and numbness, damage to teeth, etc. So you just have to weigh out the pros and cons.
All right. Thank you so much, Dr. Aronovich. That's been a very, very comprehensive lecture here. For those who are taking the course, this is going to help you to answer the question. He has when would you have another time to come back? I know this is we agreed for 2 lectures though.
Yeah, we can talk about that offline and figure something out.
Okay.
There's one other question here. If bone grafting and implant placement are done at the same time, will it increase the success rate of the implant? So that's a great question. And again, it depends. Are you grafting at the same time just to augment and support a thin buccal plate where the implant was placed? In that case, it should be fine. But if you're doing a bone graft to cover over the implant threads, let's say 50% of the implant is exposed and you're placing a bone graft to cover it, then you need autogenous bone against the implant, and then you need some cadaveric or other bone peripheral to it. But I would say, in my experience, the success rate is going to be lower if you have to graft to cover over the implant threads. Ideally, I want the implant, when it's placed, to be completely covered by bone, and I only graft at the same time with implants, ideally in cases where I'm just trying to further improve the aesthetics of the ridge and further support a thinner labial plate. So I'm going to make sure that as the replacement substitution process happens, as the bone heals and remodels around the implant, that we don't lose that labial plate. And in that case, I think it works pretty well. Another question, is it possible to have the bone graft and the implant done in a single visit? Again, I think I just answered that question.
Yeah, I think so.
Yeah.
Wow.
Perfect. Well, thank you all.
Thank you so much. Really appreciate it. You're just right on time. Thank you.
All right. Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator